Hi, I'm Dr. Jennifer V. Brown, your stroke specialist, and today we're going to talk about getting the proper ankle range of motion measurements to get the best fitting and functioning ankle foot orthosis. Most of my clients already come to me with an ankle foot orthosis and they want training to improve their walking. But a lot of them have inadequate ankle range of motion in order to get the proper mechanics of walking. The first thing I notice is a lot of them are pistoning, meaning their heel is popping out of the AFO, and hence you see a lot of these straps across the ankle, which doesn't do anything to help ankle dorsiflexion, the movement of the tibia or the leg coming forward in order to get more ankle range of motion to get your body from behind you to in front of you needed for walking. Also, when there's inadequate ankle range of motion, you see what we call closed chain plantar flexion when the foot is on the ground. The leg stays behind the ankle joint. And what you see in the knee is what we call knee hyperextension. And that also leads to a lot of pain. And so there's a couple things that I do. I often change the direction of the strap, and I've talked about that in a previous video. Did you see it? Why is there a strap across the ankle portion of the AFO? And I use a spandex strap depending on the muscle weakness, or sometimes I have to use a rigid strap if there's a problem like spastic equinovarus. But the first and foremost thing that I do with all of my clients is that I measure their ankle range of motion in multiple positions. So I do it in weight bearing and non weight bearing because when you walk, your foot is on the ground and it's up in the air. And if they had adequate ankle range of motion and we could strengthen their muscles, they would need an AFO to clear their foot. So I often start off with the ankle in sitting and I measure it with the foot on the floor. You may have to use a book and you may have to use a flat edge goniometer so the middle portion, the center of that goniometer doesn't hit the floor. And I ask them to scoot forward, keeping their heel on the ground, and I measure their range of motion. And I also measure it if I can place it on the surface with the ankle um, on the surface and I measure that range of motion. But I usually ask them to move and measure that final motion, and the heel has to stay on the ground. I measure it in mid stance, so when their hip is aligned over their knee and over their ankle. Then I measure it in terminal stance, in which their knee and their hip is in front of the ankle. Technically, the heel is up because the toes are bent about 20 degrees, but right before they get to terminal stance, I measure it with the heel on the ground. And then I measure the ankle range of motion in loading response. And that's when the foot touches the ground and the knee is bent, and they need about 15 um, degrees or so of ankle range of motion. But definitely they need 15 to 20 of the knee bending in order to get adequate ankle range of motion. I do believe that measuring the ankle in a functional position is so much better than us measuring it as we were taught in school because you're laying down on your back, you're not loaded. And your vestibular system changes, how your body alignment, you tend to see posturing, things change. The term clinical hypertonicity, you increase tone in order for stability because you're upright. And so I'm doing all of these measurements in functional positions, and then I have a discussion with the client as well as with the orthotist to make the optimum, best fitting and functioning ankle foot orthosis for the clients. I also look at the hind foot specifically because if there's something like spastic equinovarus, the foot stays inverted at the heel and pointed down and in. And so during different phases of gait, your hind foot moves. So it's inverted on loading response, or I'm sorry, on heel strike. And then in order to load the foot and get your body weight forward, into loading response in mid stance, it goes into eversion. And so I use an inclinometer to measure the hind foot as well as the forefoot because I'm looking how the dynamic changes of the foot occurs. And I need that flexibility to occur in the ankle foot orthosis. So none of my foot plates are rigid. It has to accommodate the movement from the hind foot to the midfoot to the forefoot. So, what are the clinical questions to ask? Is there a contracture present at the heel cord causing the range of motion loss? And if so, how do we change that? Do we have to do serial casting? Does there has to be a surgical intervention? Is there muscle weakness contributing to range of motion loss? And I find that we're strengthening muscles of the foot one way, concentrically. What about isometrically and eccentrically to help with that movement at the talocrural joint known as the true ankle joint? Is there tone or spasticity contributing to range of motion? And how are you mitigating that or using it to your advantage? And then last, is there a sensory impairment causing the range of motion loss? Not only do you have to ask these clinical questions, you got to think of um, how you're measuring clinically also for the goniometric placement in terms of ankle range of motion. So I tend to align that movable arm with the heel part of the calcaneus and really look at the hind foot. I'm not paying attention to the fifth metatarsal. And um, I think I also consider if the person wears what type of shoe they wear. Because if it's a woman and they tend to wear a heel a lot, they may already have some heel cord shortening. And so they may not have as much dorsiflexion movement at the talocrural joint. And therefore, in their AFOs, I may set them in a little bit of plantar flexion because they're going to wear a heeled shoe that they're accustomed to. And I make sure I put a Velcro strap at the knee portion to allow the leg to come forward so there can be gains in range of motion during the stance phase. Remember, always go to your references for evidence-based practice and apply them to clinical practice with your clients. Social determinants of health really matters. For example, like the type of shoes a woman wears affects their ankle range of motion. Remember, I'm your trusted source for all things ankle foot orthoses and stroke neurorehabilitation. See you at the next video. Thanks for watching. Bye-bye.